Good morning, Sarah Ann. Welcome to day 2.
Well, it's morning here in the Western Hemisphere, but our European friends are saying good afternoon, and our friends even further across the globe.
It's tomorrow.
It's tomorrow.
It's Saturday morning.
So,
Right.
welcome whatever time you're joining us from.
Yeah, so day 2, yesterday was jam-packed and exciting, and I think today is more of the same. Do you want to tell us a little bit about the content?
Absolutely. Today we will be giving away our second William B. Long Award, and we're really excited to introduce you to our recipient this year, a very worthy recipient, and be hearing those remarks here in just an hour. So,
Terrific.
2 more scientific sessions this morning, another one this afternoon. So we've got a lot to do.
And just as a reminder, all registrants have access to the content from yesterday and today, and the additional recorded content for 12 months. So please avail yourself of that opportunity and share the information as you see fit.
Absolutely. Also this afternoon, we will be seeing the official baseball toss from Dr. Shiroff to Dr. Mario Gaspari, who will be our incoming president. So the baseball toss is a Cwis tradition.
Yep.
So we decided to make that happen virtually this time, going from Philly all the way over to Milwaukee.
Terrific. All right. Well, without further ado, let's get on with the show.
Thanks so much.
While we wait for Dr. Ko to manage some technical issues, we're going to go with the second presenter, Dr. Diego Oliveira Brinhes. He's from Colombia, and he's going to be presenting management of multiple rib fractures at the University Hospital CòCUTA in Colombia. Dr. Diego, as soon as we have your slides on, you can start your presentation.
Yes, now. Dr. Diego, can you hear us?
Yes, I hear.
Okay, Dr. Diego, you can start now. Yeah, we can hear.
You can start.
Okay. Good morning for everybody. Welcome again to this session. My name is Diego Oliveira. I'm from Colombia. We hope you can enjoy this presentation. Our research management of multiple risk factors in University Hospital of CòCUTA, Colombia. We don't have any conflict of interest. And so, CòCUTA is in Colombia, South America, in the border with Venezuela. We designed a retrospective study with adult patients with traumatic risk factors and surgical fixation with stratos and strato system. And the most important, we applied a tooling, a survey with name SATIS score. Okay. We work with 50 people in overage, 84% of men with 48 years old in our age, and we including foreign people around 16% correspond to Venezuelan people. We admit the people in 70% in emergency room, and they have secondary trauma in 70% by motor vehicle, secondary to motor vehicle, and 18% by falls. This is our perioperative characteristics, and most importantly in this is the previous surgery, because 68% was a thoracostomy. In the fractures characteristics, we found 4 ribs and 5 fractures with a distribution in first position in right side with 46%, then left side with 40%, and finally with the lateral with 14%. And they have in 88% have associated injuries, with distribution, and most importantly, in chest, in first position with hemothorax, then pneumothorax, and then with contusion. They have two abdominal injuries, nervous system injuries, and lens maxillofacial injuries. Our principal indications of surgery was flechas, but we found 8 patients with incorrigible pain with needed surgery fixation. Okay. In general, our patients, 46% needed hospitalization in intensive care unit over age 6.2 days, with mechanical ventilation in over age 5 days, and it's more importantly, after surgery, they needed mechanical ventilation around 1.3 days. It's more quickly breathing, change to breathing, spontaneous breathing. Okay. In our hospital, we delayed the surgery around 9 days, but we fixed 4 ribs with 5 clips in average. We use BAT in all patients. It's important for our patients because they have more frequency injuries, associated injuries. Only 3 patients was outcome, 2 patients with cervical site infection, and 1 patient with chronic pain. Okay. The long hospital stay was 9 days, more or less 6.4 days, and the surveillance medical was 105 days, in a range to on 18 days to 300 days. And the most important thing too is a status score, because in general our patients describe improvement of patient and mobility too after the surgery, and they say or report or show lower consumption of pain medication, analgesics or another medication. They say to low reconsult after surgery, and they agree have another surgery again in a same situation. Okay. So we can conclude our patients have a marked improvement in respiratory pattern and faster change to spontaneous breathing, and they have faster from hospitalization in intensive care unit to general hospitalization and fast medical discharge. Also, the surgical delay in average about 9 days didn't show an association with chronic pain or another outcome. And more important, when we use BAT in all cases, it allows us to evaluate and correct injuries, associated injuries, especially in allows of the liberation of the pulmonary parenchyma when exist secondary abrasions. And the most important, the very important conclusion is the perspective of the patient. That surgical stabilization improves notably the quality life from the perspective of patient, including in patients with severe risk fracture and non-flexures. In the video, we can check a patient with 48 hours post-surgery, after surgery. the mobilization and mobility, the mobility and the breathing and the pain, control pain is good for them. Thanks a lot for paying attention, for the opportunity, especially from our team and our boss, Marcel Quintero.
Thank you, Dr. Diego. It's Dr. Rivas from São Paulo, Brazil. It's a pleasure to be here. It's an honor to participate in this splendid meeting. Thank you very much for all the team that organized everything. I can't see any questions here from the audience, but I have two questions for you. Very simple. First, your trauma is
I'm sorry.
severe.
Sorry. Dr. Chris, it's Dr. Christie's turn to discuss the paper. Dr. Christie?
Oh, sorry.
Yes, I'm here. I'd like to congratulate the investigative group on winning a research grant and applying it towards the better study and understanding of rib fractures. I applaud you for this award, and I consider winning a competition for grant funding one of the highest accolades that a researcher can achieve, so my hat's off to you. I also compliment you and the investigative group on your high-quality work. The debate of SSRF and the influence the procedure has on flail chest is settling in the favor of rib fixation, and in my mind, the bell tolls for those arguments against SSRF in the flail chest patient. And I agree with your sentiments as reflected in your manuscript. However, as you stated, there is more work to do. As your paper points out, with the exception of the non-flail studies, the majority of work detailing SSRF as a surgical option are either flail investigations or studies where flail and non-flail patients are in mixed analysis. In short, more data is needed to allow for a clear perception of the advantages, risks, and patient selection criteria for non-flail cases, and your work will certainly add to the growing body of evidence that SSRF and non-flail cases improve aspects of patient outcomes, specifically reflected in your quality of life assessments. I have one question, if time allows. I have others, but one question in particular. The paper describes approximately 9 days of surgical delay. If you could you expand on this delay, specifically why there was a delay and what trends you might have identified in terms of other injuries, comorbidities, transfer, or referral pattern issues that may contribute to the delay? And again, I applaud you for your excellent presentation, your paper, and thank you for sharing this with us and the rest of the world.
Okay. Look, in this country, our hospitals don't have all machines with tomography or another I don't know, imaging, because it's a city. Our city is a small city, yes. Okay. So our patient has delayed the tomography and another exam, yes. And so I can pass we can apply the surgery. We can make the surgery in this patient between 9 days or more, and maybe they need pay particular in another center a tomography or a reconstruction, three-dimensional reconstruction.
Okay. You conclude the answer.
Okay.
Okay, so now I can just make one question for him, because they show us a lot of hemothorax. Almost 50% of the patients that have hemothorax, and a lot of people receive transfusion. How you manage this hemothorax in the time of the surgery or before that? How do you manage the hemothorax for 9 days until the surgery?
Okay, it depends, because our patient is more frequently was hemothorax, severe hemothorax, yes, because in my country it's more frequently this mechanism, the 70% by motor vehicles, including a motorbike. It's more frequently motorbike. So this patient most frequently was severe hemothorax, and the general surgeon resolved the emergency, the hemothorax, with a thoracoscopy. It's not frequently in our surgeries access to the pleural cavity and clean the hemothorax or another primary injury.
Okay.
Okay, thank you. I have to move.
Thank you, Dr. Rivas. Thank you, Dr. Bringes. Thank you.
I need to have a clear for this.
Okay.
But in these patients, we don't have primary surgery, but in our surgery, in then moment or a next step in the stabilization, we everybody every time have a video thoracoscopy, because they have adhesions, secondary adhesions. Okay.
Okay, thank you.
Okay,
Thank you, Dr.
We have to
Bringes.
move on.
Thank you.
We're going to the next presentation. So our next presenter, Dr. Robinson. Dr. Robinson